I will do that. It takes a moment just to get everything rolling.
Oh, perfect. Yeah.
We're saying that the link goes to the wrong webinar. How did that happen? Okay, I'm going to now see if I can get a link set up here. It's not good. All right, so all right, so let's see if we can do that. All right, let's see if we can do this. Okay. Let's see. All right, so here we go. Apparently some of the people here received the wrong link to the webinar, so we're resending that out. But we'll be ready to start here in just a moment.
Yes, no problem.
And so we're just going to wait one moment here and then we'll get rolling. I apologize for the delay.
Oh.
So. All right, looks like we've got more than 100 already on board, so we're going to get rolling here.
Our mics are not on, right?
Yeah, so you're fine.
Okay, all right.
Welcome. My name is Jeff Kuznia, and you are on the CortiCare webinar series where we present topics related to EEG, neurodiagnostics, patient care management, research, and future applications of EEG. Today's event will last between 45 minutes and an hour, and later you'll receive an email with a link to evaluation form for the webinar. And you have to complete and submit that form in order to receive 1 continuing education credit from ASET. On this webinar platform, you can enter your questions in the chat area, and time permitting, we'll raise all those questions and have them addressed at the end of the presentation. The use of stereo electroencephalography has rapidly increased over the last decades with advances in imaging, source localization processes, and robotic-assisted procedures. Particularly in evaluating and treating patients with complex refractory seizures, SEEG is a critical tool. Its proper application involves drilling holes in a patient's skull and precisely placing multiple depth electrodes in the right locations of the brain to record 100, 200, or more channels of EEG. But before that happens, the neurologist must decide where in the brain to locate the electrodes, and that requires analysis of seizure semiology, the signs and symptoms of seizure progression, to formulate a hypothesis for SEEG. And that's the primary topic of today's webinar. And presenting is Dr. Amar Kader. Dr. Kader received his medical degree from the University of Damascus. He completed his training in medicine and neurology in England and was elected a member of the Royal College of Physicians. He completed 2 years of epilepsy and neurophysiology fellowship at Mass General in Boston, and followed by 1 year of advanced fellowship in SEEG and epilepsy surgery at the Cleveland Clinic. Dr. Kader was recruited to the University of Pennsylvania in 2016 to establish their SEE program, and then he was recruited to Emory in Atlanta in 2019 to lead the epilepsy surgery program at Children's Healthcare of Atlanta, where he currently serves as a director of the Epilepsy Center. He is an assistant professor of neurology and pediatrics at Emory with a primary interest in surgical epilepsy. Welcome, Dr. Kader, and I'm now going to hand over the presentation to you.
Thank you, Jeff. And
turn on your video.
Sorry. All right. Well, thank you, Jeff, for the kind introduction and for the invitation. Good afternoon, everybody. So our topic for today is related to stereo EEG and the use of semiology in SEEG. The topic is rather large for the time we have together today, but I'm hoping to be able to give you a brief overview of SEEG and how do we utilize semiology in the planning of stereo EEG. So the outline of the, I have no disclosures, so moving on to the outline, I'm going to start with some historical background, then I'm going to speak about the definition of the epileptogenic zone in intracranial monitoring in general, but more specifically also within SEEG, how do we define the epileptogenic zone? Then we will move to discussing the generation of the anatomo-electroclinical hypothesis and how do we leverage semiology to formulate a hypothesis with some examples. I'm going to briefly mention the importance of the interpretation of SEEG and also the use of cortical stimulation. So we'll start with a historical background. Stereo EEG was founded in France through the intellectual marriage of two spaces. One is the Talleyrand space. So Talleyrand was a neurosurgeon in the Hospital of Sainte Anne in Paris. And he created a coordinate system called the Talleyrand stereotaxic space, where you can precisely define the anatomic location of various structures in a grid system. Banco, who was a neurophysiologist and neurologist at the time, saw the value of using Talleyrand space to really study the dynamics, the three-dimensional dynamics of the spread of seizure activity in the brain. And in fact, SEEG has been around for a very long time. The first textbook in French on stereo EEG was in 1965. But I just want to be clear about something, that stereo EEG is not depth electrode to study epilepsy. Stereo EEG by itself, and the way it was created, is a method that relies on anatomical and clinical and electrophysiological correlation to study refractory epilepsy. So how do we define the epileptogenic zone? At least in the North American School of Epileptology, the epileptogenic zone was defined as the area of the brain that we have to remove in order to make the patient seizure-free. It's thought to be the area that is necessary and sufficient to initiate seizures, and that if we remove that area, it makes the patient seizure-free. So the concept was really heavily reliant on the idea of epilepsy being more driven by some lesion or an area in the brain, very well-defined area that can be surgically removed and will lead to seizure freedom. So as you can see, this definition is really a post hoc definition. We have to plan the intracranial monitoring, perform the surgery, and only find out if we have the epileptogenic zone or not after we make the patient seizure-free. And in terms of neurophysiology, it really depends on measuring the latencies of various discharges from different areas in the brain. Within SEEG, on the other hand, the definition is really doesn't pertain to a particular spot in the brain or particular area, but rather is defined as the area, the site of the beginning and the primary organization of the epileptic discharges and how it gives rise to semiology. So what does that mean? It means that we don't just look at where the seizures are being generated. We look at the early spread in the epileptic discharges and the evolution of the signs and symptoms. So that's the semiology. Essentially, semiology is the signs and symptoms that precedes or occur during and after the seizure. So for example, if a patient presents with an aura of deja vu, then they had secondary bilateral tonic-clonic convulsion followed by aphasia, the constellation of all these symptoms and how they evolve over time is what gives rise to semiology. So as we see within stereo EEG, the definition of the epileptogenic zone doesn't really correlate exactly with the what to remove area. And I'm going to demonstrate that with some examples. So with the stereo EEG, there is a very individualized approach to refractory epilepsy. No two temporal lobe epilepsy patients will be investigated the same way, as we will see in some upcoming examples. And there is very close link between the definition of the epileptogenic zone and the study of seizure semiology. So what are the indications of SEEG? We read a lot about various indications such as negative MRI or bitemporal epilepsy or insular epilepsy or singular epilepsy. But the fact of the matter, you can do SEEG if you have a solid anatomo-electroclinical hypothesis. As long as there is a hypothesis in place that you are going with a stereo EEG to answer the question that you build from your hypothesis, that is sufficient to proceed with the stereo EEG. Because as I would show in some examples, the SEEG can be actually done not necessarily just for curative purposes, but also for palliative. So I'm going to give you an example. So we have a 16-year-old child who has refractory seizures since age 4. And he, at the time of the evaluation, was on 5 anti-seizure medications. And he was having in the order of 4 to 5 seizures a day. And as you can see from this really very brief kind of one slice MRI image, that there is bilateral polymicrogyria, more evident over the right hemisphere. But he has a very consistent type of semiology that was consistent with a sense of buzzing in the ears, with the spinning sensation, and followed by loss of awareness. So it was clear that this was generated more from the posterior percipient area. And we have investigated this child with stereo EEG with the posterior percipient hypothesis. And we found that actually the large burden of his seizures was from the angular gyrus. So you can see from this intracranial investigation with SEEG, there is abundant spiking in the angular gyrus and very clear low voltage fast activity that is emanating from the angular gyrus. So the child actually underwent a removal of the angular gyrus of the non-dominant hemisphere, that was the right side, and his seizure frequency dropped to 1 every 2 weeks. So a tremendous kind of improvement. He's not seizure-free, but his quality of life has improved tremendously with this intervention. And this is the case now for 18 months. So it's a sustained seizure improvement. So trying to kind of zoom in more on the anatomo-electroclinical hypothesis, I'm going to start with a case study. We presented with a 31-year-old right-handed female who has seizures since age 21, and her seizures are expressed as a sense of fear, followed by deja vu with right hand automatism and lip smacking, and occasionally generalized tonic-clonic seizures. Now, seizure duration is important when analyzing seizure semiology, because we know temporal lobe seizures, at least mesial temporal lobe seizures, tend to last a little longer. The scalp EEG was suggestive of right temporal lobe onset, and the MRI was normal. So this is a case of what we call MRI negative epilepsy that we really should go ahead and investigate, at least in this particular situation. So the patient underwent a stereo EEG implantation, and what I'm showing you at the top is MRI slices with the red dot correlating with the location of the electrodes. The electrodes of interest have been highlighted on the left-hand side, and on the top, you will see the emergence of symptoms as the patient is developing the seizure. So what we see is we see pre-ictal spiking in A and B, which are in the uncus and the hippocampus. And then we see nice evolution of rhythmic spiking into low voltage fast activity, correlating with the patient's sense of fear. As we move forward, the patient complains of deja vu, and we see the epileptic discharges evolving to the entorhinal cortex, then to the premotor cortex with right hand automatism, then lip smacking when the discharges hit the opercular area. So this is a nice demonstration of the evolution in terms of time and space and frequency. So what we're seeing is we're seeing the evolution of the discharges from low voltage fast activity or rhythmic spiking to slower frequencies. We see them propagate in time, and we see them evolve in space, invading surrounding structures. And at the same time, we're seeing the semiological expression of symptoms. So what do we actually do when we're planning stereo EEG? As I've demonstrated in this example, we have pre-ictal spiking followed by rhythmic spiking followed by low voltage fast with evolution to various structures. And I'm seeing the evolution of symptoms and sign, or the semiology, over time. What we do in analyzing semiology and planning stereo EEG is we take the semiology and we actually go back to try and make an inference as to where the seizures could have been generated from. So this is almost like the inverse problem that we do in neurophysiology. You take the semiological signs and symptoms and you analyze them and you bring them back to where could the onset be. So trying to really identify the epileptogenic network from the semiological signs and symptoms. So how do we use semiology when we're formulating the anatomy electroclinical hypothesis for SEEG implantation? So here is the same example that we mentioned earlier, but with different signs and symptoms. this particular example, the patient has fear and deja vu behavioral arrest propagating rapidly to generalized tonic-clonic seizure, but the seizure duration is rather brief, is only 45 seconds. So we have an emergence of bilateral generalized tonic-clonic seizures almost immediately after the aura. In this particular case, there is an indication of an engagement of the lateral temporal lobe, perhaps the temporal pole, the temporal neocortex, rapidly at the time of seizure onset. And this has been studied very well in the SEEG literature, as noted in this paper from the Marseille group. They defined the temporal lobe epilepsies into 4 different subtypes, where there is a pure mesial temporal lobe type, as I explained in the first example. But for this particular example, this would fit more in a neocortical or mesial lateral type of epilepsy, where there is rapid engagement of the mesial temporal lobe. So what does this mean for us? It means that the first patient potentially might benefit from an intervention that would address only the mesial temporal structures, whereas this patient will not be made seizure-free unless we address these other structures, such as the temporal pole or the lateral neocortex, meaning a mesial temporal ablation, for example, will work for the first patient, but this particular scenario, we will likely need a more wider destructive procedure. So this demonstrates 2 things. First is that semiology is really critical in the implantation, and that SEEG can actually help us also guide the treatment better when we have good understanding of the semiology and the evolution of the physiological and the clinical signs over time. So I'm showing here a really small graph just to illustrate the difference between the first case and the second case. In the first case, what we've seen slow evolution of symptoms over time with slow devolution. So, and this is typically the case in mesial temporal lobe epilepsy, whereas in the last case, there is very rapid emergence of symptoms with rapid generalization, which is typical when you have an engagement, rapid engagement of the lateral temporal structures. And this is really kind of a key difference between these two, because it will guide the implantation better as well as it will guide the treatment later on. Now, if we take a third scenario where the semiology is slightly different, so we do have fear and deja vu, but the patient also complains of auditory illusions, so such as, the sounds are louder or fainter. In this case, we know that the auditory cortex is engaged very early on, and the auditory cortex in its location is further away from the mesial temporal structures. And this is an entity that has been recognized for a while now, is called the temporal plus epilepsies. So these patients do not really do well with the standard temporal lobectomies because it does not address the wider network that is involved in generating the epilepsy. And I'm going to bring you an example, one of our patients actually, a 32-year-old female who has seizures manifesting as auditory illusions and also some visual symptoms very early on before secondary generalization. The MRI was consistent right mesial temporal sclerosis. The PET scan showed concordant right temporal hypometabolism, and the video EEG clearly demonstrated right temporal lobe onset. The neuropsychology evaluation was also consistent with right temporal lobe dysfunction. So traditionally, what we've done in these situations is these patients would go on and have a standard temporal lobectomy. And this is indeed what happened in this case. This patient was seen as at an outside facility and had an anterior temporal lobectomy. Unfortunately, her seizures were not well controlled, and she continued to have seizure. So what we did is we looked at the imaging, and we've seen that at least on this sagittal view, we see that the anterior temporal structures have been removed, but this structure here is called Heschel gyrus, and this is part of the auditory cortex that have not really been removed at all. And we were concerned based on the semiology that there is an involvement posterior to where the resection has taken place. So what we did, we studied the patient with stereo EEG, and we implanted the planum, which is a part of the auditory cortex, the superior temporal sulcus, the supramarginal gyrus, and the angular gyrus. And the stereo EEG clearly demonstrated seizure onset from these structures posterior to where the resection took place. We have done resection of those structures. This was a non-dominant hemisphere, so it was okay to do that. And the patient has been seizure-free for almost 2 years now with this procedure. But the first intervention, which was anterior temporal lobectomy, did not render her seizure-free, unfortunately. So I want to kind of bring in an important concept when it comes to seizure semiology. We do have the idea, the notion that perhaps symptoms and signs are generated in the brain by some kind of switch, that there is a spot in the brain that generates a sense of smell. There is a spot in the brain that generates this kind of behavior. And that's not entirely true, as I would show in a couple of upcoming examples. The idea of having switches in the brain is almost similar to the phrenology concept, if you like. And to just show the complexity of some of those sometimes, I'm going to bring you an example about olfactory auras. So if the patient presents with, let's say, a sense of smell, burning smell, at the beginning of the seizure, where do we localize this to? Traditionally, these patients were thought to have mesial temporal lobe epilepsy. So, the amygdala and the hippocampus, for example. But we know, anatomically speaking, that the olfactory cortex, the part of the brain that processes the smell and can generate the smell, is quite complex. So we have a primary olfactory cortex that is usually residing in the piriform cortex and near the amygdala, what is called the periamygdaloid complex. We know that the entorhinal cortex, which is part of our memory system, can also generate smells just based on that memory kind of circuits. The orbitofrontal cortex, which is part of the frontal lobe, can also generate olfactory auras. So is the insular cortex and the hippocampus. So as you can see, there are multiple structures that can be implicated. And to make things even more interesting, these two sides of the brain are connected with the anterior commissure. So if somebody presents with an aura of burning smell, how do I decide which structure is responsible and which side? The answer is with the evolution of symptoms and signs over time, looking at the EEG and looking at the seizures. If the patient has an olfactory auras, followed by right hand automatism, followed by generalized convulsion, it's completely different than if they have an olfactory aura, followed by behavioral arrest and no motor manifestations, for example. The localization will really be heavily dependent on studying the evolution of symptoms and signs over time with the aid of scalp EEG. And that would bring me to my second point about the semiology is the semiological signs and symptoms are not always generated by the switch, as I said earlier, but they're also generated by synchrony and desynchrony amongst various structures in the brain. So we're still learning more and more about the various networks in the brain, and these are wired differently in each one of us. And that is also true for epilepsy patients. For example, if the patient presents with humming as part of their semiology, if they have humming, the stereo EEG has demonstrated that this particular sign is generated through a synchrony between the superior temporal gyrus, which is our kind of auditory cortex, and the inferior frontal gyrus, which is part of our speech or language area. So as you can see, there is not really one switch. We have two switches here that would have to be turned on at the right frequency, meaning both cortical areas would have to be linked with the right oscillation, if you like, in order to generate that particular symptom. So it's not just one switch, it's actually two, and they have to be linked with the right amount of oscillations in order to generate that behavior. In terms of desynchrony, we think that, for example, the amygdala is responsible for generating fear behavior. If we activate the amygdala, we get fear behavior. And that's the traditional teaching, at least semiologically, that fear is generated from the amygdala. But again, stereo EEG has demonstrated that a loss of synchrony between the amygdala and the orbitofrontal cortex can actually generate fear, meaning seizures can be generated from the orbitofrontal cortex, and because we lost that connection with the amygdala, ultimately we get the fear behavior. So these two examples demonstrate that semiology at the end is not a byproduct of activation of particular structure in the brain, but rather there is more complexity to this. Now, the story is a little different when it comes to primary cortices. For example, the primary auditory cortex, when it's activated by itself without activating surrounding structure, can generate symptoms such as buzzing sound. The same is true for primary visual cortex. If we activate the primary visual cortex, we get flashes of light. But as we move away from the primary cortex, things get a little more complicated. So the localization triangle, as I would like to call it, is really related to this interplay between the anatomic structures, so that's the anatomy, so let's say the auditory cortex, the physiology, so you want to hit the cortex with the right amount of frequency that would generate the symptom. Because sometimes fast activity can actually deactivate or silence the cortex, if you like, depending on which structure we're looking at. And then ultimately that leads to the generation of the behavior or the semiological features. So there is always this really complex interplay between the anatomy and the physiology that ultimately lead to the semiological symptoms and signs. And to just bring that one step further, I'm going to talk about how signs in evolution can mean different things. And to just bring an example of that is the head version. So if a patient has versive head turn to one side as part of their seizure semiology, the presence of this sign much later on in the seizure, as in this example, would mean that the seizures are probably generated in the temporal lobe, then traveled to the frontal eye field, where we typically see the symptoms being generated from activation of the frontal eye field. So if this symptom appears over a minute from when we see the seizure onset, it is likely that it's not being generated from frontal lobe epilepsy, but rather temporal lobe epilepsy, spreading perhaps through the temporal pole into the frontal lobe, activating the frontal eye field and leading to head version. The story would be completely different if you get very early head version. So if the patient has head version within the first 14 seconds of seizure onset, it's likely that it's from much closer structures. So you will see that more often in frontal lobe epilepsy, or less commonly in dorsolateral parietal epilepsies, for example. There are many other possibilities, obviously, but the point I'm trying to make is that even the presence of certain signs would have to be looked at in the evolution of the entire totality of the seizure, rather than just using a snapshot of semiology and using that by itself as the one and only sign to tell us about localization. So the whole concept of having an individualized implantation maps can be prone to flaws. And the reason for that, as I've demonstrated in the earlier example on the temporal lobe epilepsy with auditory features, if we have a standardized template that we use in our practice, we will likely miss some very important structures in our sampling. So, for example, a temporal lobe implantation such as this one would have 7 electrodes that would cover superior temporal gyrus, middle temporal gyrus, inferior temporal gyrus, and deep into the amygdala and the hippocampus, as well as the temporal pole. But if the patient has auditory illusions with visual symptoms, it is likely that visual cortex is here, auditory cortex is here, that the problem potentially lies somewhere there. And we really need to address that specifically. As I said earlier, the nice thing about SEEG is it can be tailored to patients. No two implantations would necessarily be the same because you're studying that particular evolution of symptoms and signs over time in that particular patient. So how do we formulate a hypothesis, the stereo EEG? The first question we have to ask ourselves is where is the seizure being generated from? So if we have a patient who presents with fear and déjà vu, we would most likely think of the mesial temporal structures, the amygdala, the hippocampus. But then we have to ask ourselves, could the seizures have been generated from surrounding structures and then spread to these structures to produce the semiology? That's a very important question. And as we've seen in the prior examples, it depends on the dynamics of the spread of seizures and how these symptoms and signs are generated over time. Can we make an inference based on the evolution, the clinical and the electrographic evolution, as to where the various possibilities of where these seizures are coming from? So this will be almost like a 3-dimensional assessment of the epileptogenic network, if you like. And when we're able to answer that question, we can then plan trajectories to try and maximize our gain with sampling. If my hypothesis is mesiolateral temporal lobe epilepsy, I will likely discuss with my colleagues and our neurosurgeon to sample certain lateral structures and then feed in the electrode into the mesial structures to try and maximize the data that we can gain with certain trajectories. The challenge is if we build an SEEG based on a wrong hypothesis, that's going to lead to inadequate sampling of the cortical areas that potentially are capable of generating this epilepsy. Then the interpretation is going to be inaccurate, and it will lead to poor surgical outcome. And I've heard this sometimes where some of our colleagues would say, well, the SEEG just doesn't work. And the fact is, it will only work if there is a good hypothesis to investigate with stereo EEG. So more on semiology, because I think semiology is really key to what we do with stereo EEG. And I'm going to bring in some examples here. So this is a 21-year-old male with a history of seizures since age 13. And the semiology was described as behavioral arrest with rocking back and forth, followed by laughter and falling. And the seizure duration was about 40 to 60 seconds. And he was having daily seizures. So this seizure would fall into the category of what we call hyperkinetic seizures. But what we've seen, this is a scalp EEG. What we've seen, the patient is asleep, and as you can see, immediately with arousal, we see instantaneous tachycardia. So there is very early tachycardia as part of the expression of semiology, and that was kind of missed the first time around when the patient was presented for pre-surgical evaluation. So trying to work our hypothesis based on the fact that the patient has early tachycardia with this hyperkinetic features and laughter, then falling if he's standing up. What are the potential areas? Well, tachycardia is an autonomic sign that is usually generated from multiple structures, but some candidates will include the amygdala, the insula, the cingulate cortex. But then taking the behavioral arrest and the hyperkinetic behavior, we have to think about frontal lobe sampling in the premotor cortex and perhaps the cingulate motor area. The laughter, if it's mechanical, without emotions, it's probably being generated also in the frontal lobe, more precisely from the cingulate cortex. And then falling is probably related to what we call the negative motor area, which is present. There are two of those. One is in deep in the brain in front of the supplementary motor area mesially, and one is present laterally near the pars triangularis. So based on the constellation of symptoms and sign, we thought that this will most likely represent insular epilepsy with various spreads to generate these symptoms and sign. And indeed, the patient did have insular epilepsy. He underwent laser ablation and he's been seizure-free for a year. This is another case of a 10-year-old male with history of refractory epilepsy who has a negative MRI and on 3 anti-seizure medications. He was having 5 to 10 clusters, so his seizures come in clusters, and he will have 5 to 10 clusters per day. The semiology was very clear. He has immediate eye deviation to the left with asymmetric tonic posturing where there is a stiffening and elevation of the left arm and leg. Then it proceeds to bilateral tonic-clonic movements. So based on the analysis of semiology, it was clear to us that the seizures are being generated from the right hemisphere, most likely close to the superior frontal sulcus and the frontal eye field, activating the supplementary motor area to generate the asymmetric tonic posturing of this particular type. The patient was investigated previously at an outside facility where he had 17 electrodes implanted, and there was, as you can see, very heavy coverage in the frontal lobe, in the central lobe, and also in the parietal cortex. We've investigated this patient with only 9 electrodes, and we were more interested in this area where electrodes B and C are. And indeed, we found the seizure onset to be in the superior frontal sulcus. The patient underwent laser ablation, and he has been seizure-free for 18 months, where previously he was having 5 to 10 seizures per day. Indeed, he has some noticeable left arm weakness when I met him the first time, and that has now completely recovered to baseline. I'm going to speak briefly about MRI abnormalities and how sometimes we rely very heavily on imaging and we don't pay enough attention to clinical signs and symptoms. This is an example of a child who presented to our center with seizures manifesting as behavioral arrest, sometimes preceded by visual hallucinations, and very little in the way of motor signs. He has nodular heterotopia on brain imaging that is kind of closer to frontal horn, and therefore it's within the frontal lobe structures as such. But the semiology did not really make much sense for frontal lobe, and his EEG showed temporal lobe onset. We investigated this patient with a stereo EEG, and we found the seizure onset to be actually in the fusiform gyrus, as you can see, with rhythmic spiking followed by low voltage fast activity. Fortunately, we were able to map him and exclude any potential functional deficit from the fusiform area, because usually the fusiform area is involved in facial recognition, and he underwent laser ablation and has been seizure-free for about a year. I'm going to bring in another caveat of imaging where we have had 3 different patients who presented with various semiologies. The first patient had stiffening of the arms, eye fluttering, and drooling. The second patient has sudden outburst of laughter and staring with right eye twitching. And the third patient had burning sensation over the left arm and leg and mouth with twitching on the left side. All these patients had opercular hypometabolism on PET imaging, which looks specifically for areas of hypometabolism that is thought to be implicated in the epileptogenic zone. We studied the first two with a stereo EEG, and both of them have been seizure-free for almost 2 years, and we found focal cortical dysplasia on biopsy. The third patient actually underwent a resection guided by ECOG because he did have focal cortical dysplasia on imaging. And unfortunately, that did not make him seizure-free. And part of the reason was because this complex sensory phenomena is probably being generated from the association sensory areas and areas 2, which is very deep into the operculum. And that is not really easily accessible with ECOG. So the patient eventually underwent stereo EEG and became seizure-free. But resecting the lesion with the guidance of ECOG did not make him seizure-free. Here is another example of a patient who presents with hypermotor semiology. You can see very early on there is a lot of muscle artifact with tachycardia, and there's very little to see in terms of EEG evolution. But the patient has seizures manifesting with gyration and restlessness, and it was kind of clear to us that it's most likely being generated from one of the hyperkinetic circuits that we understand now a little better. Indeed, we did find seizure onset to be in the mid-cingulate cortex. He underwent an ablation and has been seizure-free for 2 years. The hyperkinetic seizures are kind of quite fascinating. We looked at those using SPECT imaging, and they come in 3 different varieties. One where there is the rocking back and forth, so a movement along the anterior-posterior axis of the body. And the second type is more of a rotational along the kind of long axis of the body. And the third type is more a combination of these two. And we know from stereo EEG and from SPECT imaging that these are mediated by different networks. So it's important to kind of, again, pay attention to these really subtle semiological features sometimes that can guide the implantation successfully. In terms of interpretation of SEEG, I want to touch briefly on that because it's important to look for certain patterns when looking at the SEEG. So things such as rhythmic spiking with low voltage fast usually carry a much better prognostic outcome than some of the slower patterns. And this is a graph from a very nice paper that was published a few years ago where they looked at outcomes in correlation to the seizure onset. So those who are seizure-free, which is the blue bar, are those with poly spikes prior to low voltage fast or low voltage fast activity. And as you can see, anything that has low voltage variety to it tends to do a little bit better. Here's examples of patients who unfortunately did not have very good onset and were not made seizure-free with an intervention. This is an example of temporal-polar onset where you can see there is not really a clear evolution. It's rather very slow compared to some of the earlier patterns we've seen. This is another example of seizure onset in the dorsolateral prefrontal cortex. And as you can see, it's probably more in the beta frequency band. And these patients tend to do less well than those where you have low voltage fast activity. The low voltage fast and rhythmic spiking will indicate that perhaps you're closer to the epileptogenic zone than some of the other patterns. One interesting thing that we can look at with the stereo EEG, actually, we can look also at DC shift or ictal baseline shift. And these also can correlate very well with the epileptogenic zone. In fact, sometimes we can look at dipoles within the intracranial recording. So in this particular paper, you can see the ictal baseline shift with negative deflection of the slow wave in the hippocampal head and a positive deflection in the hippocampal body. So this is a nice demonstration of the co-occurrence of low voltage fast activity and DC shift or infrared slow sometimes can be equally helpful in delineating the epileptogenic zone. Moving on, just a brief outline of the cortical stimulation. So cortical stimulation is used in SEEG not just for mapping, it's also used specifically to induce seizures. And this notion was kind of rather foreign in North American epilepsy surgery practice for many years. But we do have solid evidence to suggest that those seizures that are induced during stimulation, especially if they replicate the electroclinical representation of the spontaneous seizures, carry a much more favorable outcome. So if you're able to replicate the patient's seizures both electrographically and clinically with the stimulation, you're more likely to make this patient seizure-free. And this is the example of our patient from earlier with the fusiform gyrus epilepsy. We were able to demonstrate with a high-frequency stimulation the electrographic and the clinical manifestation of his epilepsy. Things will be even better if you're able to induce seizures with low-frequency stimulation. The low-frequency stimulation perhaps carries a better positive predictive factor for seizure freedom than high-frequency stimulation. So it's something to keep in mind that the stimulation is used not just for functional mapping, but also for seizure mapping. One other thing that we can do with stereo EEG is we could do cognitive and emotional mapping. And I'm going to give you an example of a patient who presented with olfactory auras prior to her seizures, and we implanted the piriform cortex, and then we presented her with various scents. And you can see here, so the red would present the power of the activity, and this is in the gamma band. So on the right-hand side, you can see this is up to 115. So we've seen higher gamma and low gamma buzz at different frequency band with presenting the patient with different scents. We've also used the same technique to look at memory mapping, where we give the patient some items to remember, and we've seen high frequency oscillations in the hippocampus. Then when we ask the patient to remember those, we've seen activation in the temporal neocortex. So this is, again, another nice tool that we have at our disposal with stereo EEG. One last word about low-frequency stimulation that can be used to generate cortical evoked potential. So we can stimulate one site. For example, we can stimulate site A and then look for cortical evoked responses in other sites. And usually we will be looking at what we call N1 and N2 to measure connectivity within the brain. And this is an example of a live patient that where we did stimulation of the temporal pole. And you can see that there are cortical evoked responses in the entorhinal cortex, the temporal gyrus, and the fusiform. Now, the application of this can be pretty good when you have uncertainty about seizure onset in terms of therapeutics. This is an example of a case that we've submitted for publication. This is a patient who had periventricular nodule heterotopia, but was studied with stereo EEG. When we implanted the patient, we saw seizure onset in the posterior hippocampus and occipital temporal gyrus, as well as in the heterotopia. So we did cortical evoked responses, and we saw that the heterotopia was closely connected to the hippocampus. We saw this nice gamma bus in both areas. So this patient underwent an ablation of the heterotopia only, and that made her seizure-free. We did not need to ablate the hippocampus, given that it was the dominant side and there was concern for potential memory problems. The stereo EEG can also help us look at the involvement of the subcortical structures in the brain, and this is an evolving field. So we can leverage stereo EEG to learn more about brain functions and about the anatomic and physiologic correlation. So in summary, I hope that I was able to demonstrate that semiology is really essential for stereo EEG, that SEEG is not really a depth EEG, but rather is a method that is based on the anatomo-electroclinical correlation. It should not really be used for just lateralization of seizure onset. It should be just a hypothesis-driven. And we can always leverage SEEG to help patients, but also to advance our understanding. At the end, I'd like to acknowledge our staff at the epilepsy centers, both Emory and the Children's Healthcare of Atlanta. And I want to thank our patients and families who trust us with their care and teach us every day how to be better at what we do. And I'd also like to thank our trainees and thank you all for listening and for your attention.
Thank you. Thank you for that. As it's clear, this is a complex solution to a complex problem. And it takes clearly a lot of thought and planning to use it appropriately. When I first started getting involved with high-density EEG and SEEG recordings, I don't think it was as clearly appreciated how the planning had to be tied into the progression of the seizure. And it was really looking at, can we get in and find out if it's coming from this area of the brain or not? And I could understand now that as it gets more refined and you understand more the pathway that the seizure progresses through, that the effectiveness of this type of approach is going to improve. We have just a few questions. One of them has to do with kind of the logistics of it. How often have you seen where you implement SEEG according to your hypothesis and then still have to go back and maybe burr more holes and apply more electrodes and look at a broader area?
Yeah, this is a great question. And unfortunately, sometimes we do have to go back, particularly in situations when you don't see a good onset necessarily, but you know that you're very close. Or sometimes in some of these temporal pulse cases, we feel that there is a need for more posterior coverage. We do this not very often, I have to say, but sometimes it just has to be done. It'd be nice if you're able to sometimes make an inference based on your data, whether there is sufficient information to guide an intervention. But if there isn't, the onset is not clear, I think, unfortunately, you have to go back and put more electrodes.
How has the more advanced imaging impacted this? Are you looking at higher resolution? Are you looking at more functional type of imaging? How is that playing into the hypothesis planning?
It all comes into play. I think certainly high resolution images, 3D MRI. We do have some advanced post-processing that can take place, such as VBM or voxel-based morphometry. I think functional imaging can also be essential. The PET and SPECT can actually guide the implantation, the network, because sometimes what we see, even when we see hypometabolism on PET, it's the hypometabolism of the network. For example, in these perisylvian cases that I showed, the 3 patients, we saw that there was some hypometabolism in the insular opercular area, but it wasn't the resolution of those is not as good as the stereo EEG. But we like to think of this as more kind of blending all the data together into guiding the hypothesis ultimately. I think every piece of data can be helpful. Sometimes we only need a PET scan, MRI scan, and neuropsychology evaluation. Sometimes we really need to dig more and get more data, get a mega scan, bring the patient back for SPECT if we feel that there isn't really enough data to guide a hypothesis.
And with the aspect of feelings and sensations and all of that, the reticular activating system gets involved with all of that. And is there anything particular related to how that functions in assessing the seizure activity?
This is a very great question, and it's very fascinating because I think we know very little about the subcortical involvement in epilepsy. we know that it's part of the circuit. For example, the basal ganglia is part of this frontal lobe. There are 5 different circuits that involve the basal ganglia and the frontal lobe, and we don't always investigate them. We don't know how the thalamus or other subcortical structures potentially take part in this, but it has to be kind of kept in mind. So if someone has an arousal, is this a physiological or is this an epileptic arousal and I'm missing the onset because I'm on scalp, for example? We have to look at that evolution of symptoms of signs over time in order to, say more confidently, is this a subcortical physiological activation or is this epileptic, if you like? Does that answer your question?
It does. It does. There's a question here about, how long do you monitor once you have, the SEEG electrodes in place? Obviously, you're trying to capture events and, look at the patterns that emerge. But how many days does that normally take?
So we typically monitor for a minimum of 5 days, just because sometimes we have patients who have seizures every day, but we like at least the first night, they're kind of post-implantation, they're probably tired, and sometimes you get micro bleeds post-implantation. So we like to just get things settled in the first night, and then we have to give them a break before we do stimulation. So the shortest we've done is about 5 days, but we have had patients stay as long as 28 days. The FDA approval is for 28 days, but we have had patients stay longer just because we were unable to capture seizures. And ultimately, it's the balance between, your confidence in the data. Would one seizure be enough for your purposes with the addition of stimulation? Do you need to capture more seizures? And we're usually very transparent with the patients about that. We say, look, we only have one seizure. We've done stimulation. This is as good as we can go. And you've been here for, say, 28 days. It's hard. That's not always the case, but mostly on average, it's about 7 to 10 days. Most of our patients stay 7 to 10 days.
Okay. All right. Well, thank you. It was a great presentation. Look forward to maybe having you come on board again in the future. And we look forward to all of you joining us again in October or November for our next webinar. Thank you again.
Thank you. Thanks a lot. Bye-bye.